Hi, so today we're going to talk about Mohs surgery. This is probably the question I get most frequently in clinic every single day is what does Mohs stand for? The answer is it doesn't stand for anything. So Mohs is named after the individual who developed the technique. His name was Frederick Mohs for the removal of higher risk skin cancers. So higher risk skin cancers typically occur on the head and neck for reasons because we have so many blood vessels and nerves and pores in this area of our skin. So the chance of them recurring or coming back is higher. So most of the time we're working on the head and neck area. There are high-risk skin cancers in other areas of the body. There's something called the appropriate use criteria that really tells us exactly where we do perform this procedure, just to make sure that we're always doing the right thing for the patients. So if you're having Mohs surgery, it's usually to treat, or should be to treat, a high-risk skin cancer. The other part of Mohs surgery is that it's a tissue-sparing procedure. It means that we don't have to take a lot of tissue in order to remove the cancer because we check the margins while you wait. So it can be a few-hour procedure, but most of that time is waiting time, not time that you're actually having the procedure performed. So if you're coming in to have Mohs surgery, the first thing that happens is you get numbed up, just like when you had a biopsy done. Then the surgeon will do something called curette the area, and that scrapes the surface of the wound and helps us define that initial margin that we're going to cut out and remove and process. So the cancer is more friable. It breaks apart easier. So when we curette it, it helps us again define that initial margin. We then cut just around that, usually 1 or 2 millimeters around that area, and process that tissue while you wait. So the cutting out is really, really important because the surgeon needs to take a thin piece of tissue with a beveled edge so that we can give that tissue to the histotech, who will then process as a flat piece of tissue. The idea is we can see 100% of the peripheral margin, meaning the edges, and the deep margin in one, meaning the bottom of the cancer, in one plane. So when we're looking at the slides, we see 100% of that, and that's why the cure rate is so high. So the skill of the surgeon removing the cancer and the quality of the slides that the histotech produces are really key in making sure that this procedure works. It has a 99% cure rate for basal cell skin cancers, but it only has that higher cure rate is if the histotech makes great slides for the surgeon to interpret. So I hope this is helpful. Mohs surgery is really just for the removal of the cancer. Once the cancer is removed, then we have lots of decisions that we can talk about together. It's a decision between the patient and the surgeon on how we fix the wound that was created from the removal of the cancer. So we'll talk about that in another session, but I hope this was informative and gives you some ideas about what to expect if you have Mohs surgery.